Bismillah Rahman Rahim. The topic is emergency obstetrical ultrasound in first trimester, and I am Professor Dr. Syed Ahmed Gilani, representing Afro-Asian Institute of Medical Sciences, Lahore. The first trimester ultrasound have got a few very important emergencies. The first and very important emergency is bleeding or pain in first trimester. When a patient comes to us with bleeding or pain in pregnancy of first trimester, it can be a normal intrauterine pregnancy or it can be abnormal intrauterine pregnancy having bleeding and pain. If it is abnormal intrauterine pregnancy, if we can have a failed pregnancy, which is spontaneous abortion, or a failing pregnancy, which is impending abortion, which means that there are signs, symptoms which are indicating toward the loss of pregnancy. The third option is that the patient got ectopic pregnancy when patient comes with complaint of bleeding and pain. Now, in such conditions, the key questions will be, does the sonogram demonstrate intrauterine gestational sac when we are scanning? On our ultrasound, the report is demonstrating the evidence of intrauterine. Are the gestational sac and its contents normal? Usually in the beginning, we will have the gestational sac with amniotic fluid, with an amniotic sac, with yolk sac, which is usually extra-amniotic, and an embryo, early formation of embryo. And obviously, another important thing will be the cardiac flicker or cardiac activity, depending on the age of the gestational sac in first trimester. The third thing we have to look for in the documented sonogram in the report is, are the adnexa normal or not? The ovaries are normal or not? Intrauterine gestational sac identified. If on ultrasound it is identified, we can have two situations. One is that it is identified, and second situation is that it is not identified. If it is identified, we will look for the sac and contents, if they are normal or not. If they are normal, then diagnosis is normal intrauterine pregnancy. If the sac and contents are not normal, then the diagnosis will be abnormal intrauterine pregnancy, definite or possible pregnancy failure. Whereas the other situation can be that the intrauterine gestational sac is not identified. If it is not identified, then we will look for the extra ovarian complex or solid mass, anything lying outside the uterus, or extra ovarian outside the ovaries also. If yes, then it can be ectopic, definite, or probable. There are chances that it is ectopic. The second situation is that extra ovarian complex or solid mass is not visible. The differential diagnosis can be normal intrauterine pregnancy, although the intrauterine gestational sac is not identified on ultrasound, so we can wait, or abnormal intrauterine pregnancy or ectopic. So all three conditions will be possible if we don't see extra ovarian complex or solid mass in a pregnant lady who is otherwise pregnant on the basis of beta HCG or pregnancy test. If there is embryo with cardiac activity, we will look at the embryo and yolk sac. If yolk sac is large, that also indicates abnormality. And we can have the size of the yolk sac, look at the proportion of gestational sac with the yolk sac. The embryo is not visible here, or just echogenic rings, which is double sac sign. We can get this line, and then this is the second line. So it is two echogenic rings. The normal gestational sac and contents. This slide is very important. If the gestational age is 5 weeks and gestational sac with double ring is present, that indicates normal gestational sac. So at 5 weeks, we must have a gestational sac with double ring. Double ring was this type of shape. It is must at 5 weeks. If the gestational age is 5 weeks and 5 days, then the gestational sac along with yolk sac must be present. We will look at the gestational age. If it is 6 weeks, there must be gestational sac with heartbeat. So if the heartbeat is not present at 6 weeks, the suspicion starts. So these were 3 conditions depending on the gestational age related to the gestational sac and its appearance and its contents. Then comes the mean sac diameter. If the mean sac diameter is 8 mm, there must be yolk sac. And if the mean sac diameter is 16 millimeters, there must be embryo. Beta HCG, if it is 1000, there must be gestational sac. If it is 10,800, we must have embryo within the gestational sac. When we look at CRL, the crown rump length, if it is 5 millimeters, there must be heartbeat in most of the cases. Yolk sac must be present, and it must be less than 6 millimeters. Usually we say that the normal mean diameter of yolk sac is 1.9 to 5.6 millimeters. So practically we take 2 to 6 millimeters as normal. So anything below 6 millimeter will be acceptable, but it millimeters. A yolk sac below 1.9 millimeter is not acceptable because it will be smaller. It can affect the growth, the early growth of sac and embryo. Then comes the heart rate. When the gestational age 3 weeks or less, we must have 90 to 100 beats per minute heart rate, and 100 to 110 is the minimum required from 6.3 to 7 weeks. Gestational sac is echogenic rim, little no fluid around it. Appropriate amount of amniotic fluid is seen. So the diagnosis of first trimester pregnancy failure, spontaneous abortion will be a presence with abnormal gestational sac or contents is at high risk for pregnancy failure, but may prove to be abnormal, normal. Some abnormal findings are definitive for pregnancy failure. Others are worrisome for pregnancy failure. So there are some findings, some signs which indicate definitive pregnancy failure, whereas some create some doubts. Let's see how we do the diagnosis of early pregnancy failure. The diagnosis: definite failed pregnancy. If CRL is above 5 millimeters and no heartbeat. Gestational age known to be 6.5 weeks or above and no heartbeat. These are the two conditions which make the diagnosis almost accurate, a definite diagnosis about the pregnancy failure. Then is the diagnosis: probable failed pregnancy if no fetal heart and other milestone is not met. For example, CRL 1 to 4 mm and no heartbeat. So it is still less than 5 millimeters, which we discussed here to diagnose it as definitive failure. Mean sac diameter, when it is above 16 mm and no embryo. Beta HCG 1000 and no gestational sac. Large subchorionic hematoma or yolk sac, which is above 6 mm. These are indicators towards the probability of failed pregnancy, which can lead to a definite failed pregnancy if we get these two signs which we discussed in the heading of definite failed pregnancy. Then comes the third type, which is increased risk of subsequent failure. A fetal heart and slow heart rate at 6.7 weeks, 6 to 7 weeks. So large subchorionic hematoma, yolk sac, which is above 6 mm, and low amniotic fluid volume. So crown rump length, this is the crown rump length, should be above 5 mm and no heart rate was there. So we discussed here that if it is above 5 mm, no heart rate, definite failed pregnancy. So if a patient comes to me with pregnancy and pain or bleeding or spotting, and I scan and I get a yolk sac with an embryo having a crown rump length, which is more than 5 millimeters, and there is no cardiac activity, I can give the diagnosis of definite pregnancy failure. In conditions where patients have no complaints, sometimes we wait for another 1 to 2 weeks. We can scan on alternate days to look for the presence or delayed appearance of heartbeat. There are some reported cases in which the heartbeat appears a little bit later to the normal gestational sac as compared to the normal gestational sac. So if there is no hazard, there is no urgency, and there is no bleeding, just a pain or discomfort or spotting, we can wait for the heartbeat to appear for 1 to 2 weeks, and we can keep on scanning on alternate days if required. So gestational age known to be 6.5 weeks and no heartbeat. This was a case. Look at this. The yolk sac is 5.5 weeks here, and follow-up scan 1 week later, there was a small embryo, but there was no fetal heart activity. So as per rules, it will be labeled as, because this is 5.5 weeks, and then after 1 week it is 6.5 weeks. So we can label it as failed pregnancy because the embryo is very small and there is no cardiac activity in it. Then we come to examples of probable pregnancy failure. Crown rump length less than 5 mm and no heartbeat. This is very small at 5. If this is, again, you can see the crown rump length is less than 5 mm, no heart. After 1 week, again, we can see there is a small embryo and no cardiac activity, which will indicate towards the probability of pregnancy failure. There are more chances it will be a failure. Alive but increased risk of subsequent pregnancy failure, slow heart rate. In this case, it was 80 beats per minute. So embryonic heart rate 6 to 7 weeks. There will be relationship to first survival rate. Here you can see this graph shows if it is about 100 in 6.2 weeks age, and this is from 6.3 to 7 weeks, we need about 120 here and 100 here. So if the gestational age is below 6.3 weeks, 100 will be taken as normal, the lowest limit, and 120 will be the lowest limit for gestational age when it is 6.3 to 7 weeks. And above 7, we usually take 130 to 140 as normal. So we can classify the early heart rate in early first trimester. It is slow when it is less than 90 beats per minute in till 6.2 weeks. It will be slow up to 110 when it is less than 110 from 6.3 to 7 weeks. Borderline till 6.2 weeks when it is 90 to 99, and here it is 110 to 119. Normal if it is up to 100 beats per minute, which is the minimum, and 120 beats per minute here at 6.3 to 7 weeks. The embryo is alive and increased risk of subsequent frequency failure. We get large subchorionic hematoma. This is a large subchorionic hematoma here again, and this was very large, and 4 weeks later it is still there, but there is regression of the hematoma. So there will be increased risk. Here the embryo was very small and now the embryo is growing. So it shows the survival here in this case, but we can have increased risk of failure if we have a large hematoma. So the subchorionic hematomas, there will be a risk of spontaneous pregnancy loss. We have got the classification. If there is no subchorionic hematoma, there is likelihood of loss of 7.2%, small 6.5%, moderate 20.5%, and large is 38.7%. So the risk increases. This was according to this study, which was done in 1997 by Benson et al. In Radiology. It was published, and these are the journal risks which are likely to be there, which is, it means small hematoma is almost within this range, which cannot cause much damage. It comes under the circumstances where we can have loss due to many reasons. So moderate and large hematomas are very important, but we have to keep an eye if we get even a small hematoma. So this is subchorionic hematoma. Then comes the large yolk sac. Here you can see this is 7 weeks, large yolk sac with embryo. Large means it is above 6 millimeters in mean diameter. After 1 month, at 9.5, after about 3 weeks, the yolk there, and you can see the embryo without cardiac activity, so there was a fetal demise. Then we can have ectopic pregnancy. This is a gestational sac with embryo and yolk sac. Here is another one. So the location of ectopic pregnancy is important. It's one of the very important emergencies in first trimester. Common 95% of in natural conceptions, ischemic, ampulla, fimbrial, extracornual portion of tube. Uncommon, which is around 5%, the heterotropic pregnancy, which means intrauterine plus ectopic. So there will be a twin pregnancy, one sac lying within the uterus in the endometrial cavity, and indicating normal intrauterine pregnancy, and another ectopic pregnancy. So whenever a patient comes to us with pain and bleeding, having a normal intrauterine, that patient's adnexa must be assessed intrauterine along with ectopic, which is called heterotropic pregnancy. The incidence is very low. Interstitial portion of the tube, which is the cornu, we can have at cervix, intra-abdominal, and cesarean section scars. Let's see a few examples. The patients with beta HCG symptoms and no intrauterine gestational sac, the patient's beta HCG is higher. There are symptoms of pregnancy and no intrauterine gestational sac. We can have extra-ovarian adnexal findings and likelihood of ectopic. Get mass with embryo or yolk sac, then the chances of ectopic will be 100%. Lesion surrounded by tubal ring, the chances will be 95%. Other complex or solid mass, the chances will be 92%. And free fluid, isolated or moderate, there will be higher chances, but less than 10%. Normal plus minus ovarian lesion, we can have 5%. To rule out ectopic in patients with higher beta HCG, and if we have symptoms like the pain and bleeding, the basic rule for ultrasound diagnosis are that these are the ultrasound findings and interpretation. Adnexal mass with heartbeat or yolk sac, it is definite ectopic. Extra-ovarian mass without heartbeat or yolk sac, probable ectopic. Normal scan plus minus intra-ovarian cyst or mass, possible but unlikely ectopic. Excluded. There is ectopic pregnancy with cardiac activity lying in the adnexa outside the uterus. This is another one in which you can the gestational sac with yolk sac, and it is in adnexa. This is ectopic. Here is the ovary. and uterus is showing some residual reaction, but it is empty. Again, the tubal ring. This is ovary, and tubal ring is having a small gestational sac. The endometrium is empty. This is cervix and endometrial cavity. And if I go back here, you can see some fluid also. Probable ectopic pregnancy, above 90% adnexal mass. This is the adnexal mass. There is intrauterine pregnancy within the uterus. This is ectopic, this one. Here is ovary with follicles and ectopic pregnancy. And this is another ectopic ring. So we have to rule out the gestational sac where it is ectopic. Here you can see the ovary, and we have a mass-like structure. The mass is in or beside the ovary. Here in this view, we can see it is beside. It is, we can separate it by just giving a gentle push by the TVS transducer. It will be separated. Role of Doppler in rule out pregnancy, in ectopic pregnancy in patients. It is not much helpful in most of the cases, except we are expert in doing the peak systolic velocity and the resistive index of the feeding vessel. And if we can find the proper feeding vessel, Doppler is not helpful if ultrasound shows intrauterine pregnancy, adnexal mass, extraovarian, adnexal mass, which can be intra versus extraovarian, or normal adnexal. It is potentially misleading if ultrasound shows adnexal mass with little or no flow on Doppler. Sometimes adnexal mass is there and it shows some flow, and we have history of beta HCG, which is higher, and there is suspicion of pregnancy. There are false positive reports of pregnancy, and we find adnexal mass and we use color Doppler, and if we get flow, we will have a suspicion that it goes towards an ectopic. But if we are good in Doppler and we find flow there, and we do the resistive index, spectral Doppler, and the resistive index is above, is less than 0.5, it can usually favor the presence of ectopic pregnancy. Doppler may be helpful if ultrasound is equivocal for adnexal mass, so we can rule it out. Here you can see gestational sac with heartbeat, 100% ectopic, which is because it is outside. This is a mass. Here is ovary, tubal ring, 95%. And this is normal because we have got an ovary with a follicle. It is not a gestational sac. Can Doppler help in these conditions? Just grayscale can give the diagnosis. There will be no need of Doppler scanning. Here is a tubal ring. We put the colors, there is no flow, although it is pregnancy. So in ectopic pregnancy, scan TVS and put ultrasound into one of 4 categories: ultrasound findings and interpretation regarding ectopic pregnancy. Out of the 4 conditions, the first category is intrauterine pregnancy. If you get intrauterine pregnancy and you have scanned the adnexa and you did not find any other mass, we rule out ectopic, and we rule out the heterotropic ectopic pregnancy. Number 2 is no intrauterine pregnancy and no extra ovarian adnexal mass. Ectopic possible but unlikely, about 5%. Cannot rule out ectopic in such cases. No intrauterine pregnancy, adnexal mass or free fluid, the probable ectopic will be about 90%. Embryo or yolk sac outside of uterus, it is definite ectopic. If TVS inadequate, do transabdominal scan. If TVS is equivocal for adnexal mass, do Doppler. Unusual ectopics like abdominal pregnancy, we can have coronal ectopic, cervical ectopic, heterotropic pregnancy, and pregnancy implanted in C-section scars. There is a case, a diagrammatic explanation for abdominal pregnancy. The uterus is empty. This is versus intrauterine pregnancy in which it is within the uterus. Here is abdominal pregnancy. The uterus is empty and the fetus is present in abdomen. Cervical ectopic. This is cervical ectopic and spontaneous abortion in progress. This is cervix and the endometrium. The cervical ectopic pregnancy diagnostic criteria will be the ultrasound findings of cervix, well-formed sac, prominent echogenic rim. It will be live embryo. So if we get it in the cervix, it is cervical ectopic. If it is flat, change or absent, it can be impending abortion. This is the cervical ectopic. It was lying in the cervix. The endometrium is empty. And here it is bending because it is getting irregular. Coronal ectopic pregnancy, the coronal ectopic versus the centrically located and intrauterine pregnancy is in duplicated uterus, in didelphys uterus. The coronal ectopic pregnancy diagnostic criterion will be the ultrasound findings, a centric gestational sac with little or no visible myometrium around spherolateral aspect. The diagnosis will be the coronal ectopic. The myometrium around entire gestational sac, intrauterine pregnancy in duplicated uterus. Here you can see the coronal ectopics and intrauterine in bicornuate uterus. This is the one part of the uterus and other. So bicornuate, one is showing decidual reaction, the other is having pregnancy. Pregnancy implanted in C-section scar. Here is the C-section scar and you can see it is implanted there versus the spontaneous abortion in progress with low implantation near to the cervix. The diagnostic criteria for C-section implanted pregnancy will be the prior C-section, gestational sac located low and anteriorly in the uterus, just above the cervix, gestational sac and surrounding echogenic ring, trophoblastic tissue extends to serosal surface of the uterus. This is cervix, here is the endometrium, and here is the scar, the previous scar, and a magnified view of it. You can see the yolk sac and embryo. Another pregnancy implanted in cesarean section at 5.5 weeks, 7.5 weeks, and 11.5 weeks. With this, thank you very much. these free webinars. You can visit our YouTube channel